Progress.
Colleagues, thank you for joining this webinar which we've organized, the right to sexual and reproductive health, where we are looking at understanding Article 17 of the Africa Disability Protocol. And so just to say again, as you join, please do way to write your name, your organization, and your country where you're joining from in the chat. And we would be starting in a moment. So colleagues, thank you so much. Before we start, some ground rules or some house rules that I would want us to respect in order to ensure a productive and a respectful session. We are encouraging that all participants, every one of us, engage respectfully, avoiding offensive language, hate speech, or any discriminatory comments in the chat function. We have muted the mics for all participants. This is to minimize any disruptions. So please keep your mics muted unless you're unmuted to speak by a moderator. Our webinar today has a chat function. Please feel free to use the chat functions for questions or comments and keep contributions relevant to the topic. And also be as formal as possible in the chat. So of course, we have mentioned about the the comments which you can questions, and just to add that we are recording this webinar. If you do not wish to appear in the recording, please disable videos or with this disabled videos for everyone. And we also hope that you would respect the privacy of those who are present. As this is a webinar that we're organizing within the context of the Africa Disability Protocol, I wanted to sincerely apologize for the lack of translation services and accessibility accommodations, including for persons with disability who would be joining this session. We acknowledge that this might limit full participation for some attendees, and we deeply regret that any inconveniences that we may cause. We are working to improve this in the future and to ensure that all of our events are inclusive as possible. And in the future, should you have a need for any accessibility support, please do let us know and we'll be glad to accommodate you. Thank you so much for joining this webinar. So friends and colleagues, today we've joined to talk about the rights to sexual reproductive health and rights under Article 17 of the Africa Disability Protocol. I would be your moderator, Juta Josen Jikem, SRHR specialist at Sonke Gender Justice, and I'll kick the conversation. Why is this webinar important to us? Statistics from the WHO shows that 15% of the world's population, 15% of the world population, over 1 billion people, live with some form of disability. This is, in fact, a very big number. And it also says that persons with disability are 3 times more likely to be denied healthcare than non-disabled persons. So persons with disabilities are 3 times more likely to be denied healthcare. And the reason for that is inadequate skills of service providers and poor treatment options, including accessibility. And persons with disability are twice as likely to find healthcare provider skills inadequate, and they're 4 times likely to be treated badly in healthcare settings, especially when they seek sexual reproductive health services. So this statistics is just to show you some of the challenges that persons with disability face in the healthcare settings. And in terms of accessibility, at facilities, at healthcare facilities, we also note reports have stated that there is a lack of trained healthcare workers, and the stigma which continues to restrict access to sexual reproductive health and rights services for persons with disability. And this is just to demonstrate that. Only 1 in 10 persons with disability have access to assistive products that they need to live healthy and fulfilling lives. So only about 10% of the people living with disability have access to assistive products that they would need to live healthy and fulfilling lives. So so it'll be about 10% of the 1 billion people that we mentioned in the first slide. And so we will see that it's very important to then start the conversation as to how we can change this. And we are happy that the African Union, through the African Disability Protocol, seeks to achieve that. And so this webinar, we want to talk about Article 17 of the protocol and talk about how it seeks to address issues around comprehensive sexuality education, empowerment, and overall well-being for all persons. The African Disability Protocol is a critical human rights instrument that was developed and is tailored to address the specific context of persons with disability in Africa. It was adopted in 2018, seeks to protect and promote the rights of persons with disability, ensuring their full inclusion in our communities. Unlike other instruments such as the UN Convention on the Rights of Persons with Disability, the Africa Disability Protocol takes into account Africa's unique cultural, economic, and social realities that are faced by persons with disability. So this and the protocol forms part of the African Charter on Human and People's Rights. And some of the key features of the African Disability Protocol is that it recognizes the importance of traditional values and practices and challenges harmful customs that perpetuate discrimination. It also highlights the need for intersection into how persons with disability face different vulnerabilities, starting with the gender, age, and also for those who live in conflict settings. And so the conversation here is that persons with disability face compounded layers of marginalization. And so when we talk about persons with disability, we must discuss from that intersectional view. it also, the protocol emphasizes the need for persons with disability to be included in economic development, in poverty reduction, and in access to resources. This includes accessibility to healthcare, education, and employment, and it calls on states to adopt legislative, administrative, and judicial measures to ensure the protection of disability rights. And it also recognizes Africa's history with conflicts. It addresses the disproportionate impact of war, displacement, and violence on persons with disability, something not emphasized in other global human rights instruments. And so we can say that the Africa Disability Protocol is a novel in this in the sector, and takes into consideration the different challenges that persons with disability face across the continent. And to join us, to take us through this webinar, let me introduce you to Dr. Diana. Diana is the manager of the Disability Rights Unit at the Center for Human Rights, University of Pretoria. With an expertise in disability law and advocacy, she works to promote and protect the rights of persons with disability across Africa. And on that note, I would hand you over to Dr. Diana, who is going to introduce herself, but also share her presentation. Over to you.
Thank you so much, Jude, and a very good morning to everyone. I'll just briefly turn on my camera for a few minutes so you can all see me. So as Jude has said, my name is Diana Msipa. I work for the Center for Human Rights, which is part of the Faculty of Law at the University of Pretoria. So let me just start sharing my screen now. I wonder if somebody could confirm whether you can see my presentation.
Yes, we can. Thank you so much.
Okay, fantastic. So I'm basically going to be talking about the right to sexual and reproductive health, particularly under the Article 17 of the African Disability Protocol. So before I make a start, I'd like to spend the first few minutes just introducing my organization, the Center for Human Rights. So we are an organization, I think, which we like to say that we have a dual personality. On the one hand, we are an academic department that is part of the Faculty of Law at the University of Pretoria. And on the other hand, we also operate as an NGO. So we do all the project work that any other NGO would typically do. The Center for Human Rights consists of 10 units. Some of them include the Children's Rights Unit, the Women's Rights Unit, the Migration Unit, the Digital Rights Unit, the SOGIES Unit, Democracy and Civic Engagement, Business and Human Rights, and the Disability Rights Unit, amongst others. So I work in the Disability Rights Unit, and we are one of the 10 units at the Center for Human Rights. Our sole mandate in the unit is to promote the rights of persons with disabilities across the African continent. So though we are based in South Africa, we do have a Pan-African focus. And our work is primarily guided by the norms and standards that are set out in two human rights instruments, rather two disability-specific human rights instruments, namely the Convention on the Rights of Persons with Disabilities at the global level, and at the regional level, the African Disability Protocol. It has a long name, so we tend to shorten it, but in full, it's called the Protocol to the African Charter on Human and People's Rights on the Rights of Persons with Disabilities in Africa. So, and it's usually abbreviated as the African Disability Protocol. So the unit promotes disability rights by conducting a variety of activities that can be divided into the following categories. The first category is projects. So we do projects on various thematic areas such as access to justice, the impact of COVID-19 on persons with disabilities, the rights of persons with albinism, sexual and reproductive rights, etc., etc. The second category of work that we engage in is publications. We have one publication known as the African Disability Rights Yearbook. So this is an academic journal. It's peer-reviewed and it's open access, meaning that you do not have to pay in order to access the articles that are published in that particular yearbook. The third category of work is resources. So we have one resource known as the Repository on Disability Rights in Africa. In short, it is known as RODRA. So that is an online repository that provides information and resources on disability rights across the continent. So the idea there for this particular resource is that if anybody wanted to do some research on disability rights on the continent, they would just visit the RODRA website and get some information on publications around disability rights, case law, etc., etc. And then the final category of our work involves academic programs and conferences, and this speaks to the academic part of our dual character. So we have a master's program in disability rights in Africa, which we call DRIA in short. And we also run an annual Disability Rights in Africa conference every year in November, as well as an advanced short course on disability rights in an African context, which takes place in March of every year. So I think in a nutshell, this is a brief introduction to the work that we do in the Disability Rights Unit at the Center for Human Rights. And I'd like to move on now straight into the actual presentation. And I'll start off by just giving you a roadmap of what we're going to discuss during the time that we have with us. I will begin by looking at foundational concepts, which is disability. I think it's difficult to jump into a conversation about sexual and reproductive health rights for persons with disabilities without understanding the concept of disability. So we will kick off the webinar with talking about disability, what the meaning of disability is. From there, we will talk about sexual and reproductive health as a human right, focusing specifically on Article 17 of the African Disability Protocol, what its provisions are, etc., etc. We will also look at issues that are sort of outside the African Disability Article 17 of the African Disability Protocol, but are closely related because these are the issues that the provision in the protocol seeks to address. Specifically here, I'm talking about the various barriers to the provision of disability inclusive sexual and reproductive health services. After looking at those barriers, then we will provide a few recommendations and then probably, if time permits, have some bit of engagement during a Q&A. Maybe the organizers can direct if that is permissible. And then the webinar will end at that point. So starting off with the issue of disability, what does disability mean? I think one of the things that is important to understand as a start is that disability as a concept has been understood differently over time. So that means at different intervals in history, people have had a different understanding of what the term disability means. So if you look at how people understood disability in the 1800s, it's very different to how people understood disability in the 1960s and how people understand disabilities today. So that understanding has shifted over time, and we'll go a little bit into that to show how it has shifted and the factors that have influenced that shift. And in doing so, we will take a look at some models of disability that have been developed at different intervals in history. And the importance of looking at these models, there's many, but I will highlight two for our purposes. We it's important to understand the models of disability, firstly, because it provides explanations for causes of disability. So each model will show us how people understand the cause of disability to be, right? Or how people understand what the cause of disability is. And secondly, the models are important because how you understand disability will influence how you react or how you intervene. So for example, if we're talking about legislation on sexual and reproductive health, what that legislation will ask states parties to do or healthcare providers to do is dependent on how disability is understood in a particular country. So you might have different approaches in different countries to the same issue of sexual and reproductive health and rights. And that issue, that the different approaches are not, it's not a coincidence that they just happen to be different. There is a reason why they are different. And the difference is because they are influenced by how disability is understood in a particular country or in a particular context. So those are the two reasons why we will look at the models of disability. So there are several models of disability, I think, as I've already mentioned, and each of them has a significant impact on how we respond or how we ought to respond to persons with disabilities. And I will explain just a few. I will not explain all of them because there are many and we have a limited amount of time. So just for the sake of time, I have picked the ones that I think are the most prominent ones and the ones that will help us to sort of understand the trajectory of the development of these models. So I will start first by explaining what is known as the moral or the religious model of disability. So this one is the oldest model of disability, and it is based on a Judeo-Christian tradition. So it takes various forms, or there are very different variations of the same model. So I'll just go through some of the variations. The first is that disability is understood as a punishment from God for sins committed either by the person with the disability or his parents, his or her ancestors, etc., etc. So that's a formula. The first is a formulation of disability as a punishment from God for sins. The second formulation of the moral or religious model of disability is that disability is a test of faith, which one passes through endurance and showing characteristics such as resilience and piety. And according to this particular variation, receiving healing is a sign that signifies that one has passed the test of faith, okay? And if you do not receive healing for your disability, that is also a sign that you have not passed the test of faith. So that's the second variation or the second formulation of the moral or religious model of disability. A third formulation is that disability is a blessing from God, and having a disability provides an opportunity to develop and strengthen character traits such as patience and perseverance. So those are just three variations of the same religious or moral model of disability. So regardless of which of these variations one subscribes to, what they all have in common is that they view disability as an act of God. So therefore, if disability is an act of God, then it means that disability is something that no one can do anything about because it is an act of God. So I have, I'm from a legal background. I'm not sure how many of the participants are also from a legal background, but in law, when we're dealing with contracts bind two parties, two or more parties, right, to perform a certain whatever is agreed upon, right? One of the clauses in contract law, or one of the ways in which you can get out of your contractual obligations without being sued or for breach of contract, is what they call an act of God, an intervening act or an act of God. So say, for example, if I entered into a contract with somebody to maybe supply them with a certain vegetable, and then within a certain time period by a certain time period, right? And then after I supply, the other person agrees to pay me a certain amount for supplying that vegetable. If after I've planted my vegetables, there happens to be a flood and the entire crop is destroyed, in contract law, I am not liable for that. I have not breached the contract because I am unable to fulfill the contract, but it is not through my own actions. It is through no fault of my own. It is an act of God, right? So an act of God is something that no one can do anything about, and therefore it can even absolve you from contractual obligations. So this is similar when we're talking about the moral or religious model of disability. If we understand disability to be an act of God that no one but God can do anything about, then it also influences how we respond to disability. So if there's nothing we can do about disability, we just say, oh, shame, this person has a disability, there's really nothing we can do about it except to try and alleviate their suffering and their pain, right? So we have then a charitable response that is influenced by that understanding of disability. So this is where you see most of the older laws in different African countries and even beyond Africa deal with disability from a charity or welfare perspective. So laws, instead of dealing with the rights of persons with disabilities, will focus more on welfare, how people with disabilities can be given donations, charitable donations, etc., etc. While there's a place for that, I think it is not the only response that is required when it comes to disability. So that is, in a nutshell, a description of the moral or religious model of disability and how it affects or influences the response to disability. The second model of disability that I will speak about this morning is known as the medical model of disability. So remember I said the religious or moral model is the oldest. So if you fast forward in time to the mid-1800s, that was when this new model of disability, known as the medical model of disability, began to gradually replace the moral or religious model of disability. Now, how did that happen? During this time, during the mid-1800s, there was some scientific advancements that led to a better understanding of impairments. In other words, medical professionals were in a position to better understand what it is that causes hearing impairment, for example. What is the cause of physical impairments? What is the cause of visual impairments, etc., etc. So that understanding, that more advanced knowledge, more advanced understanding on what causes particular impairments, then led to the development of what we now refer to as the medical model of disability. So according to the medical model of disability, disability is understood as a medical condition, right? So it is something that is inherent within a person with impairment, which means that it is inside them. Okay, so for the medical model of disability, having an impairment is the same as having a disability. So if someone has a hearing impairment, they are, according to the medical model, automatically a person with a disability. Okay. So because disability is understood under the medical model as a medical issue, the intervention or the response to disability that then informs or calls for is a cure where possible, or a rehabilitation to adjust the individual with impairment to their environment. So if you want to know whether legislation in a particular country subscribes to the medical model of disability, most of it will be heavy on medication, will be have an exclusive focus on rehabilitation. Then you know you're dealing with a medical model understanding of disability. Again, if you fast forward in time to the 1960s and the 1970s, this time, we see the development of a newer model of disability. Now, this model is known as the social model of disability, and it differs from the medical model of disability in that it distinguishes between an impairment and a disability. So one of the reasons why the social model was developed was that disability rights advocates noted that it is not just the issue or the thing that disables people or disadvantages people who happen to have impairments is not just the impairment, but it is also the external environment, the social environment, the environment that surrounds them, the environment in which the person with impairment finds themselves in. So it's not simply the impairment that can be problematic, but it is also one's environment, the barriers in one's environment. So the social model makes this distinction between impairment and disability. And it says that disability only arises when a person with impairment interacts with an environment which does not accommodate that person and has attitudinal and environmental barriers. So there's this emphasis on the interaction between an individual with impairment and barriers, external barriers that are in one's environment, in people's attitudes, etc., etc. So that is a social model of disability, which now saw disability as something that is created by society, right? The disadvantage is also, created by society, by the environment around us, okay? So the appropriate intervention, therefore, if you subscribe to a social model of disability, then you're essentially saying that the disadvantage doesn't simply arise or solely arise from the impairment, but it also arises from the environment. In other words, you are recognizing that the environment, other people's attitudes can also be part of the problem. So it is logical then that if you acknowledge that external factors such as environmental barriers and people's negative attitudes can be part of the problem, then it is logical that they can also be part of the solution. So from a social model perspective, the appropriate intervention to disability isn't simply about trying to cure someone's impairment, as is the case under the medical model, but it also involves making changes to the external environment. And these changes are made in response to the person's internal needs or the person's impairment and the needs arising from that impairment. So the social model says the impairment and the environmental barriers, when they interact, that is what then results in what is understood as disability, the disadvantage, etc., etc. So that is the social model of disability. So the social model of disability is now the commonly accepted model of disability. The medical model of disability is considered outdated. The moral and or religious model of disability is also considered outdated, and the social model is now considered one of the more acceptable models. I'll just say that the Convention on the Rights of Persons with Disabilities, which is the global instrument, human rights instrument dealing specifically with the rights of persons with disability, subscribes to the social model of disability. So does the African Disability Protocol. If you look at Article 1 of the African Disability Protocol, it talks about disability arising from the interaction between a person or an individual with impairment and environmental barriers and attitudinal barriers. So both these instruments, the CRPD as well as the African Disability Protocol, subscribe to the social model of disability. So I have not included a slide on this, but there is also another model, which is known as the human rights model. And both the CRPD and the African Disability Protocol also subscribe to the human rights model. So they subscribe to both the social model of disability as well as the human rights model of disability. So the human rights model of disability simply places emphasis not on the cause of disability, but on the response to disability. It places emphasis on the humanity of persons with disabilities and their entitlement to all human rights and fundamental freedoms. And so, these two instruments, the CRPD and the African Disability Protocol, take this twin-track approach where they rely and subscribe to both the social model of disability as well as the human rights model of disability. So before we proceed now to the discussion on SRH, I would just like to make note or highlight the fact that there's different types of impairments. So when we are now talking about the barriers to disability, we should remember that the barriers will differ based on an individual's specific disability. So there's different types of disabilities, including visual impairments, hearing impairments, speech impairments, intellectual disabilities, psychosocial disabilities, physical disabilities, as well as albinism. So I think most of them are pretty self-explanatory. Visual impairments are those where someone either has no sight, they cannot see at all, or they have limited sight. The same with hearing impairments. It's whether someone has either they cannot hear at all or they hear only to a limited extent. The same with speech impairments. Intellectual disabilities, I think, is a little less commonly known. So I will explain that a little bit. So when we're talking about intellectual disabilities, we're talking about a developmental disability that affects the ability to learn. In some countries, people with intellectual disabilities are known as people with developmental disabilities or people with learning disabilities. So just to help you understand, I'll give you an example of a type of intellectual disabilities, which is Down syndrome. That is a type of an intellectual disability. So it is something that someone is born with, and that disability stays with you for life. And then another less common or less commonly known disability type is psychosocial disability. So psychosocial disability is a new name that has been given to describe something that we are all already familiar with. So mostly we all know about mental health conditions. So people that have depression, anxiety, etc., those conditions that are typically referred to as mental health conditions. These are now called psychosocial disabilities. And this is in line, again, with the social model understanding of disability. And then physical disabilities, here we're talking about people who have mobility, difficulties with mobility, etc., etc. And then albinism is one of the more newer additions to the list of types of disabilities, persons with albinism. And albinism essentially, it is a condition in which somebody either lacks or has very little melanin in the hair, skin, and the eyes. So because of the lack of melanin in the eyes, persons with albinism have visual impairments. They have very low vision. And in order to accommodate a person with albinism, you would need to provide very large fonts, et cetera, considering the visual impairment there. And because of the lack of melanin in the skin, they are highly susceptible to the sun's harmful UV rays, which causes life-threatening diseases or illnesses such as skin cancer. So those, in a nutshell, are the main types of disabilities. So let's zone in now on SRH services as a human right. So if as I go along, you happen to have a question, please do free to note it in the chat box, and I hope Jude and others can help me as later on to just identify some of the questions so I can address them. So the important thing to understand is that sexual and reproductive health is a human right. Yes, it is a medical issue, but it is also a human right. What does that mean? That means everyone, by virtue of their humanity, including persons with disabilities, must be provided with sexual and reproductive health services, okay? So that means individuals have a right. On the other side of the coin, it means countries or governments have a duty to ensure the provision of disability inclusive sexual and reproductive health services. So when we're talking about sexual and reproductive health services, we are talking about a wide range of services. But here I've just put together a short list of some of the main types of sexual and reproductive services. So these include menstruation and menstrual hygiene, that's part of SRH services. Contraception is part of SRH services. Sterilization is part of SRH services. Gynecological health care, maternal and newborn health, safe abortion and post-abortion care, STIs and HIV and AIDS, services for survivors of gender-based violence, prevention and management of cancer of the reproductive system, etc., etc. All of these are examples of sexual and reproductive health services to which all persons with disabilities are entitled. So now let's look at the legislative framework or the laws that regulate the provision of sexual and reproductive health services to persons with disabilities. Because of the focus of the webinar, we will focus only on Article 17 of the African Disability Protocol. This is not the only instrument that deals with sexual and reproductive health rights for persons with disabilities, but because this is the focus of our webinar, that is what we will focus on for today. So I think I'll just rush through this part because I think Jude has already given a very good and comprehensive introduction to the African Disability Protocol. So I'll just say the African Disability Protocol is a protocol to the African Charter on Human and People's Rights. What do I mean by that? So within the African region, human rights issues are the responsibility of the African Union. And the chief human rights instrument that was adopted by the African Union is known as the African Charter on Human and People's Rights. Now, the African Charter deals with the rights of all people, the rights of all persons on the continent, including persons with disabilities, persons without disabilities, women, men, children, etc., etc. But because it is a treaty of general application, sometimes it is not it does not provide particular nuances for specific groups. So for example, it may not address adequately the issues of women, or it may not adequately address the issues of persons with disabilities. So for that reason, Article 66 of the African Charter provides for the development of additional protocols that are meant to complement the Charter or to be read alongside the African Charter on Human and People's Rights. And that is what the African Disability Protocol is. It is one of those protocols that is meant to supplement or to complement the African Charter on Human and People's Rights. It's not the only protocol. There is another protocol on women's rights in Africa. It's in short sometimes known as the Maputo Protocol. So the African Disability Protocol was adopted in 2018, and it has only come into force in May of this year after receiving, after the deposit of the 15th instrument of ratification. So Article 38 of the African Disability Protocol stipulates that the protocol will only come into effect or into force after the deposit of the 15th instrument of ratification. That means after the 15th African Union member state has ratified it. And in May, the 15th member state ratified it. And 30 days after that, the instrument came into force, the protocol rather came into force. So the particular provision in the African Disability Protocol that deals with sexual and reproductive health is Article 17. Now, I should stress that Article 17 is not titled the right to sexual and reproductive health. It's about the right to health generally. So the approach to sexual and reproductive health that is taken in the African Disability Protocol is that sexual and reproductive health is seen or conceived as part of the right to health generally. But the protocol states that this right to health also includes sexual and reproductive health. So Article 17.2 requires states parties to take appropriate and effective measures to, and I quote, to ensure persons with disabilities have, on an equal basis with others, access to health services, including sexual and reproductive health. Close quote. So that's Article 17.2 of the African Disability Protocol. So all of the provisions, the subsequent provisions that come under Article 17 relate to sexual and reproductive rights, as well as to the right to health in general, okay? So let's look at some of the specific issues or specific examples of how this obligation, the state's obligation, can be discharged. So these are all provided for in Article 17, okay? So the first is that Article 17 provides that persons with disabilities shall receive the same range, quality, and standard, okay? The same range, quality, and standard of free or affordable healthcare and programs as other persons without disabilities. And that's Article 17.2a. So here essentially the obligation is that states must make sure that the services, the range of services, the options that are made available to persons with disabilities in terms of health services are the same as the options or the range that is made available to persons without disabilities. Same as the quality and the standard of the healthcare services must be the same that is provided to persons with disabilities must be the same as that which is provided to persons without disabilities. And whether it is free or affordable healthcare, it must also be provided. If the state provides free healthcare to other persons, the state must also provide free healthcare to persons with disabilities. And there's other states that don't provide free healthcare, but they provide affordable. So the obligation is for affordable healthcare or free healthcare. depending on the country and the resources available to it. So if the country provides subsidized, affordable healthcare services to persons without disabilities, the same must be provided to persons with disabilities as well. That is essentially the gist of Article 17(2)(a). Secondly, states parties must provide healthcare services that are needed specifically by persons with disabilities because of their disability. So there may be healthcare services that other people won't need, probably because they don't have a disability, but people with disability need it. There is an obligation placed on member states by the African Disability Protocol to provide all healthcare services that are specific to persons with disabilities. So I'll just give an example, a general one. So if we take, for example, persons with albinism, one of their healthcare service needs is sunscreen. So for most of us, we can pick and choose whether we want to wear sunscreen or we don't want to wear sunscreen. But for persons with albinism, sunscreen is a matter of life and death. So the provision then of sunscreen for persons with albinism is a service related to their disability. Therefore, states have an obligation to ensure that they provide sunscreen. That is essentially what the African Disability Protocol is saying in Article 17(2)(b). Third, the African Disability Protocol prohibits disability discrimination by health service providers and also by insurance providers, medical insurance providers. I think when we spoke about the social model of disability, when we spoke about how attitudinal barriers, negative attitudes, discriminatory attitudes can also cause disadvantage to persons with disabilities. This is essentially what we're referring to here. That discrimination, differential treatment that is given to persons with disabilities because they are persons with disabilities by healthcare service providers, states have an obligation to prohibit that, to take steps in order to prohibit that, be it through educating health service providers or making it criminalizing disability discrimination in healthcare service provision, or setting a policy. The how is up to the state, but they must make sure that they take effective measures to prohibit disability discrimination. That is Article 17(2)(c). And then fourth is the provision of healthcare services is to be made on the basis of free, prior, and informed consent. And this is Article 17(2)(d). And this is particularly important for persons with intellectual and psychosocial disabilities. In a lot of countries, persons with intellectual disabilities can be sterilized without their prior knowledge, without their informed consent. The parents, even if we're dealing with an adult with an intellectual disability, sometimes the parents and the healthcare provider will agree that this person needs to be sterilized. The parents will bring the person to the healthcare facility and not even tell them, explain what they are doing, and or ask them to choose whether they would want to proceed with such a procedure. So that is one of the reasons why the African Disability Protocol has provided or made it mandatory for states to ensure that the provision of healthcare services takes place on the basis of free, prior, and informed consent. And then Article 17(2)(a) provides that provision of healthcare services must take place within someone's community. So this is to try and avoid someone having to travel many kilometers away just to access maybe contraceptives at a particular clinic, but that services must be provided within someone's community so that for easy access. And then Article 17.2F says healthcare service provision and communication between service providers and persons with disabilities must use accessible formats and be effective. So if a healthcare provider happens to get a visit from a lady, shall we say a lady with a hearing and speech impairment, that healthcare provider must not proceed to provide any services without ensuring that they first secure some kind of interpreter, a sign language interpreter, to ensure that their communication is effective between the service provider and the person with a disability. There's other ways. If a sign language interpreter is not available, there's no other family member who can interpret. There's other ways. If the person is literate, then maybe they can communicate in writing. The idea is just to make sure that communication that is effective takes place between the person with a disability and the healthcare service provider, so that the service that is provided to the person is of good quality, you know, so that people understand each other, what the person is seeking, and what, you know, so that the person also understands the options that are open to them so that they can make an informed choice. All of that is about communication. So therefore, accessible formats are crucial for this part of the process. And again, another very important issue is the provision of support to persons with disability to make healthcare decisions where needed. I think this one is crucial. Support is not simply about someone saying, okay, contraceptive options are A, B, C, D. I think you should just give them C. It's about making sure that the person understands, explaining option A, option B, option C to them, and allowing them to choose, giving them that support to say, which one would you prefer? These are the pros and cons of this particular contraceptive method, etc., etc. So that is what Article 17.2G addresses or deals with. Article 17.2H talks about health campaigns that must include disability-specific needs, but must do so in a manner which does not stigmatize persons with disabilities, and designing of services that minimize and prevent further disability. Then the final provision, Article 17.2I, is about ensuring that the training of healthcare providers takes account of disability-specific needs and the rights of persons with disabilities. Okay, so that's an important one. When we spoke earlier about disability discrimination from healthcare providers, much of it is because they have not been sensitized, they've not been trained. And this provision on training can go some way in addressing some of that disability discrimination. The second half of this provision deals with ensuring that formal and informal healthcare services do not violate the rights of persons with disabilities. So for formal healthcare services, we're talking about clinics, hospitals, and the like. And informal, maybe we're talking about someone just visiting someone at their home and they're providing healthcare services. You know, there's these sort of informal services in the African context. The state also has a duty to regulate those. So it's not just about regulating clinics and hospitals, but it's also about regulating the informal healthcare service sector. So these are the provisions. There's a lot of them, but in a nutshell, all these provisions that are included in Article 17 seek to achieve disability inclusion in the provision of health services and sexual and reproductive health services. So when we speak about disability inclusion, we're talking about making sure that persons with disabilities have the same opportunities to participate in all aspects of life on an equal basis with others. And we're talking about reducing the number of barriers in order to ensure meaningful participation by persons with disabilities. So what are the barriers to persons with disabilities accessing sexual and reproductive health services? So these are important. These barriers are the issues or the problems that the provisions we have just read are seeking to address, okay? And I think it's important for us to know them. So the first is communication and informational barriers. So this includes the inability to communicate with a person who needs sign language interpretation. That creates a communication barrier. It also creates an information barrier. Healthcare service providers who do not have access to a sign language interpreter are unable to provide adequate information to the patient because of that communication barrier. It also includes the lack of information, as I said, in accessible formats. The lack of SRH information in accessible formats can also present a communication and informational barrier. So say, for example, someone goes to a clinic and they're visually impaired. And again, I will stick to the same example of contraceptive options, and then they ask for the options in terms of contraception. And the nurse is busy on that day and hands them a pamphlet that explains. So the pamphlet is just in plain text. It's not in Braille. It's an accessible format. It's in a format that the person cannot access. So in other words, there's no effective communication that has taken place. You have not provided any information because you have not provided it in an accessible format. And then there's also lack of information about contraceptive, safe abortion, etc., as well as reproductive rights. That's the first barrier, is communication and informational barriers. Communication barriers really, really play a huge part in persons with disabilities failing to access sexual and reproductive health rights. The second barrier is institutional and policy barriers. So here we're referring to government policies, clinic policies, hospital policies, and strategies that probably deny access to sexual and reproductive health programs, services, benefits, and opportunities to persons with disabilities. So there's policies, for example, that will say someone with an intellectual disability or a psychosocial disability cannot receive access to maybe an abortion without their parents present, even if they're an adult. Those kinds of policies can also be barriers as well. A third barrier is attitudinal barriers. So this is negative attitudes towards persons with disabilities on the part of healthcare service providers and caregivers as well. So it takes attitudinal barriers, take many forms. So we are talking about here discrimination and stigma. So we're talking that this includes disrespectful and offensive treatment by healthcare workers, the community, and also family members. And we're also talking about restrictive social norms. So that is an attitudinal barrier as well. So for example, resistance by family members to women and girls with disabilities making use of family planning services and contraception. Low self-esteem is also an attitudinal barrier. So because it prevents persons with disabilities from seeking information about sexual and reproductive health rights, because they've internalized or learned that they're not supposed to be having a normal sexual life, or they're not supposed to be thinking about having children because they have a disability. And because they've been hearing that for so many years, it impacts on their self-esteem and prevents them from even having the courage to go forward and seek sexual and reproductive health services. This is a phenomenon that is referred to as learned helplessness. And then there's also misconceptions and myths about persons with disabilities that are also part of attitudinal barriers. So for example, it is sometimes believed that persons with intellectual disabilities, or even persons with disabilities generally, are asexual. They have no sexual feeling, no capacity for sexual feeling, or they are hypersexual, like they're crazy about sex, or that they're unsuitable marriage partners or parents. So all these misconceptions and myths cause people to deny or to block people from disabilities having sexual and reproductive health services. If you shouldn't be having a child because of your disability, or if you're asexual because of your disability, then there's no need to teach you about the different modes of family planning, or about safe abortion, etc., right? And then another barrier is physical and environmental barriers. So these are barriers that have to do with physical access, maybe to a place where healthcare services are being provided. So inaccessible health facilities, for example, steps, narrow entrances that wheelchairs cannot go through, and inaccessible toilets for wheelchair users. Physical barriers also include the lack of necessary equipment in healthcare facilities. People with mobility impairments might need accessible beds. So these are the beds that you can adjust and lower, so that a person sitting in a wheelchair can easily shift from their wheelchair to the bed without having to need someone to pick them up and treat them without dignity, right? And then there's also the issue of inaccessible public transportation. This is huge because particularly in rural areas, some healthcare facilities are located very far away and require persons with disabilities to travel there, and public transportation is inaccessible. So it makes it very difficult for them to even get to the healthcare facilities because of that barrier. Barrier number 5 is the lack of recognition of legal capacity of persons with disabilities. Here, it's a legal term, but in very simple terms, it means the failure to protect the decision-making autonomy of persons with disabilities. So, for example, laws that restrict capacity to consent to sex, or criminalize sexual intercourse with persons with intellectual disabilities. Zambia, Uganda, Botswana, these are the examples of countries that make it a criminal offense to have sexual intercourse with a person with intellectual disability. Doesn't matter whether they consented or not, but the fact of having sexual intercourse with a person with intellectual disability is punishable by up to 14 years imprisonment. The issue of forced sterilization, again, is about not recognizing the decision-making capacity of some persons with disabilities. They won't give you the option to decide whether you want to be sterilized or not. Also, the issue of involuntary admissions, I think, is also another issue, where they don't allow you to decide whether you want to be hospitalized or not. They just do it. And involuntary treatment, they don't give you the option to choose which treatment you want. Do you want surgery, or do you want to just go through a course of medication? They decide for you, and that is the barrier, is the failure to protect and to recognize the decision-making capacity of persons with disabilities. And then another, I'm almost done, please bear with me. Another barrier is sexual and reproductive health programs that are not monitored or evaluated for disability inclusion, and the lack of awareness of their rights on the part of persons with disabilities. If you don't know that you have a right to something, it is very difficult to enforce it. So it's important, again, for people with disabilities to know what their rights are in terms of sexual and reproductive health. And then the final barrier is limited access to reasonable accommodation during healthcare service delivery, including sign language interpreters or decision-making supports. So when we're talking about reasonable accommodations, we are talking about modifying or changing something for the purpose of ensuring that persons with disabilities can ensure their human rights and fundamental freedoms. So if you modify the process in which you would maybe get someone to consent to a particular treatment, if ordinarily you would get their consent by asking them to read a form, to read and sign the small print, if you modify it for a person with a disability and explain the small print one by one, that is a modification, that is a reasonable accommodation that you are making for the person with a disability. Okay. So the final part of my presentation is to do with recommendations. So I'll just rush through these a little bit for the sake of time so we can have a bit more time to discuss. The few recommendations for some of the barriers that we've identified. First is to involve persons with disabilities in the development of sexual and reproductive health policies and programs. If you involve persons with disabilities in these, they will be able to inform that we actually need this and we need that and we need that. That is the best way to get disability inclusive policies and programs. The second recommendation is to develop materials on sexual and reproductive health, specifically targeted for persons with different types of disabilities. So developing SRH materials in Braille, in easy to read language for persons with intellectual disabilities, and plain language version also for persons with intellectual disabilities. Or in audio formats for persons who are blind or, et cetera, et cetera. And then the third recommendation is to address attitudinal barriers by providing disability awareness training to caregivers, parents, and healthcare service workers. Another is to make premises where sexual and reproductive health services are provided physically accessible. That means provision of ramps, adjustable beds, etc., etc. And then providing reasonable accommodations as needed. So that means whenever you have a person with a disability in front of you, simply ask, how can I help you? How can I make this easy for you? They will tell you how they can be accommodated. And finally, for states to ratify and implement the African Disability Protocol. So far, only 15 states have ratified the African Disability Protocol. There are 55 African Union member states, so 40 are yet to ratify the protocol. So those 40 must ratify the protocol. And the ones that have ratified it, the 15 that have ratified it, must implement the African Disability Protocol. So I think I will stop there. Thank you very much. Jude, I will hear from you if you would like us, how you would like us to do the Q&A session. Thank you for your time.
Good day, colleagues. My name is Runyararo Mutariswa. I am the SRHR coordinator with Sonke Gender Justice. I'll be taking over moderation for the question and answer section. We have about 18 minutes or 17 minutes left on the call now, colleagues. So I'll kindly ask that we show by raising our hands, should we have any critical questions or comments for Diana to answer. Thank you very much. Paul, I see that your hand is up. Kindly go ahead.
Amo, are you able to?
Are you with us?
Hello, am I audible?
Yes, now you're audible. Kindly go ahead.
Okay, thank you very much for the wonderful presentation, and it was very much comprehensive. I have got two questions. My first question is on the protocol, the Article 17 we're dealing with, sub-Article 2. I just wanted to check if there are no similarities in Article 17, sub-Article 2G and sub-Article 2D, because they speak of informed consent, both of them. If maybe they can just be explained both of them at the same time, maybe I would understand them better and their differences. So then my second question is on the barriers we spoke about. We spoke about restricting capacity to sexual intercourse of people living with disabilities. It takes me back to the kinds of disabilities we spoke about earlier, which is intellectual and psychosocial. I just want to check, do we also would like to people with these two kinds of impairments not to be restricted capacity to sexual intercourse as far as consent is concerned, and also between the two, the intellectual and the psychosocial disabilities. I just wanted to check where can which of the two can we associate the what is called in Latin the non-compos mentis between the two. Those are my two questions. Thank you.
So non-compos mentis meaning?
Non-compos mentis, let's say we are speaking people with intellectual, not I don't want to say intellectual because I wanted to say someone with with a mental, let me call it a mental disability for a lack of a better term. I don't know if I'm making sense.
Okay, thank you. Will we take a few more questions and then I'll just address them at one go?
Thank you very much, Patrick. Kindly go ahead.
Yes, good morning to everyone.
Good morning, you're audible. Go ahead.
Yeah, I just wish to ask if the materials of representation can be provided to us. So the presentation was very fantastic and I gained more from that. So I wish if I could have the materials, the documents, so it will be very good for me. Thank you very much.
Thank you, Patrick. I'm sure that can be arranged. There's a hand from Yari. Yari, do you want to go ahead?
Yes, thank you very much. Can you hear me?
Yes,
I really did enjoy the presentation. I just have a comment. At the beginning, there were statistics that were shared that at least 15% or 15% of the population is living with disability. And throughout your presentation, we've seen the types of disabilities, and there are many. Does that 15% encompass all these types of disability? Because I feel like there's a possibility there could be more, especially if psychosocial disabilities are included.
Thank you very much, Yari. That is a brilliant question. And maybe it speaks to the updating of statistics to accommodate the changes in the understanding of disabilities. I'm sure Diana will be able to speak to that. There's a hand from Lucky Padiri. Kindly go ahead, Lucky.
Thank you very much, ma'am, and thank you for the presentation. This is Lucky Padiri from South Africa, Sakau, representing Sakau. I just want to know in terms of the physical and environmental barriers, that what can we do as maybe the organization legally to force all these institutions for them to be wheelchair friendly and everything. That's all from me. Thanks.
Thank you, Lucky. We have a question in the chat from Jose. I hope I'm pronouncing your name, and please forgive me if I'm butchering it. But the question is, can you talk about people with disabilities and sexuality and reproduction, since often policymakers and decision makers do not cater to their needs? Diana, I'm not sure how you want us to proceed. Do you want to take all of the questions, or perhaps we can pause and you answer the ones that you've received so far?
Okay, I think we can pause and then I'll address the ones that we have now. So the first, I think, was about what is the difference between Article 17.2D and 17.2G. Am I correct? Did I capture that right?
Yeah,
So-
you captured it correctly.
Okay, thank you, sir. So 17.2D talks about the provision of healthcare services on the basis of free, prior, and informed consent, okay? And then 17.2G talks about a provision of support to make healthcare decisions. So the difference, they are related, you're right, but there is a difference between them, and the difference is this. Article 17.2D, talking about the provision of healthcare services on the basis of free, prior, and informed consent, is creating an obligation for states to make sure that all healthcare services are provided on a basis of free consent, prior, and informed consent. Okay, so there is that obligation to make sure that someone is consenting, that consent is free and it is informed before any healthcare services are provided, right? So it's more, the emphasis is on making sure that there is consent, okay? And that consent is informed and it is free, that there isn't someone next to them saying, yeah, say yes, or choose this or choose that it is free, it is their own consent. And then the informed consent part is what is linked to Article 17.2G, because that creates an obligation for support to make healthcare decisions. And usually that support takes the form of simple explanations, breaking down the options, making sure someone understands. So that is support for decision making. In order for someone to make an informed decision, they need to have a range of information. So that information needs to be provided, needs to be explained. So that is the support, and any other support that they need in order to make decisions. So they are related, but they are different in terms of emphasis. And then the other question was, do we want persons with intellectual disability and persons with psychosocial disability to be able to consent to sexual intercourse? In short, the answer is yes. From an international human rights law perspective, another provision that we did not look at, but which is crucial to this and many of the things that we have been discussing, is Article 7 of the African Disability Protocol, which talks about the right to legal capacity. So this says that all persons with disabilities, not some persons with disabilities, not people with physical disabilities, people who are visually impaired, but all persons with disabilities, including psychosocial and intellectual disabilities, have the right to legal capacity. That is the capacity to decide, or the right to decide. So this includes the right to decide, to make decisions relating to consenting to sexual intercourse. Now, it's a right. In practice, for you to help someone to be able to make an informed consent about sexual intercourse, that means someone needs to go through sexuality education. They need to be taught about what constitutes abuse within the context of a sexual relationship. How do you make a choice about a sexual partner? What should you consider? How do you have safe sexual relations? So from a practical point of view, there's a lot more that is involved, but from a rights perspective, the right is there. So one of the things that is important to note about Article 7 on the right to legal capacity is that it says that persons with disabilities have a right to receive support in order to exercise their legal capacity. So, which means that they need to, to receive support in order to exercise even their right to a sexual life. So yes, my answer to that is yes, we want that to happen for them. The other question was, does the 15% encompass all types of disabilities? In short, this was a 2011, I think it was Jude that alluded to these statistics, but I know these are from the World Report on Disability that was done in 2011. I haven't checked the methodology that they used in terms of data collection, but my guess is that they looked at all types of disabilities. I don't know what they considered disability, what they didn't consider disability. I would need more information to be able to answer that one accurately. Then the other one is, what can we do legally to force institutions to improve physical accessibility? So it's a legal obligation, right? So that is one of the reasons why we are looking at the African Disability Protocol. I didn't ask which country the person was from, but if you were from South Africa, I'm not sure, sir. If you were from South Africa has ratified the African Disability Protocol. That means South Africa has agreed to be bound by the terms of the African Disability Protocol. And so what you can actually highlight to the government that they need to now start implementing the obligations that are in the African Disability Protocol. But a quicker way from a legal perspective would be to use domestic legislation. And one of them is the Constitution. I think you can use the Constitution to talk about equality, non-discrimination. There's also PEPUDA from a South African perspective. Yes, so domestic legislation that talks about accessibility and disability, that prohibits disability discrimination. Those are, I think, should be your go-to provisions. Then the final question that was, can you talk about persons with disabilities and sexuality and reproduction? I didn't understand that. Can you talk about them? Yes, I think you should talk about them, even if there's a lot of silence about it. People don't talk about it. They don't want to talk about it. It's uncomfortable to talk about. But from a human rights perspective, it is something that we need to talk about, because the right to sexual and reproductive health is linked to other rights as well. It's linked to the right to family, the right to found a family, and that's important. It's an important part of who we are as human beings. We have a right to found and establish a family. I'm not sure if I missed any, Rinyaro, but over to you.
Thank you, Diana. I think you managed to handle all of the questions that have been asked. Tato, I see that your hand is up. Unfortunately, we only have 2 minutes left. I'm going to kindly request that you type your question in the chat, and then perhaps Diana will respond to that question. I believe that we will be sharing the slides. Confirm for me, Diana.
Yes, I will share them.
Yes, so when Diana shares the slides, she will also respond to your question that will be in the recorded chat. There's also a question from Katlego that says, I would like to ask, okay, sorry, now I can't access my chat. Just a sec. It asks, I would like to ask what the recommendation is of disabled people coerced to sterilization without giving consent. So maybe this is from a legal perspective, Diana, what would you recommend for that? But I believe that we're out of time, and so I will ask that perhaps you can answer those 2 questions, the one from Tato and the one from Bongi. Together when you shared the slides, the presentation slides. Jude, do you want to close the meeting, or I can go ahead?
Unia, please go ahead.
Okay, so I'd like to express our profound thanks to Diana for such an elaborate and very, very simplified presentation. You really brought us into the understanding of disability, and I would like to believe these are echoed sentiments that we definitely feel like this is going to improve our engagements, not only with persons with disabilities, but also with lawmakers as we engage in advocacy around provision of services, especially sexual reproductive health rights services for people with disabilities. So thank you very much for all of you colleagues that have managed to join. We will be sharing the slides together with answers to the 2 questions that were asked in the chat. Otherwise, enjoy the rest of your day, your morning, afternoon, depending on where you are in Africa. Thank you so much.
I wrote this song for my hero, Mom. This song is